Now going to Antoinette for a Triclip for severe tricuspid regurgitation. Is Antoinette here?
Hello.
She's here.
Hello.
Antoinette, we can hear you.
Great. Can you see me?
We can see you.
Great. Continue. I'm just going to share my screen. Can you see my slides? Good. Hello, everybody, thank you. Can you see my slides? Excuse me first. Thank you. So I'm going to talk to you a little bit about the Triclip for severe tricuspid regurgitation and a little bit about our experience with this technique and technology. The tricuspid valve, it's always the last valve on the program. So it's the forgotten valve, really. But it shouldn't be forgotten because tricuspid regurgitation, severe tricuspid regurgitation, has significant symptoms and mortality associated with it. These patients are rarely offered surgery. So for isolated tricuspid valve surgery, it's very rarely performed, and the average length of time from the diagnosis to the actual intervention can be up to 8 years. So it's something that we follow for a long time, but are very hesitant to intervene upon. And for those patients who have had a surgical intervention and maybe have had an annuloplasty ring because of maybe left-sided disease and concomitant coronary artery disease, they have a high risk of tricuspid regurgitation recurrence. And those patients are almost never offered surgery because they're extremely high risk operative candidates and can have post-op mortality of up to 40%. So when we talk about tricuspid regurgitation, I mean, the weight of the tricuspid regurgitation comes from secondary causes. So it's functional tricuspid regurgitation due to any cause of left ventricular dysfunction, which is a primary cause, any underlying cause of pulmonary hypertension, or anything that causes RV dysfunction. So that's the major cause of tricuspid regurgitation. Primary, it's about 25% of what we see. I think it's very important to say that we see a lot of it now with pacemaker leads and defibrillator leads, and up to a third of those patients can have significant tricuspid regurgitation after the implant. And then there are more structural and congenital causes, but it's certainly the lesser part of what we see. So medical treatment for tricuspid regurgitation, well, it's not very good news for the patient. The tricuspid regurgitation can be seen as a prognostic marker for patients who have heart failure with reduced ejection fraction. So once you have over moderate tricuspid regurgitation, so this is a lovely series from Serrano in the Mayo Clinic, you can see that you're getting mortality of up to 50% once you get over moderate tricuspid regurgitation at 2 years. So it's a very significant prognostic indicator and a very bad sign for patients. And this is independent of the pulmonary pressures. And I have to say also that functional tricuspid regurgitation, it's independently associated with pulmonary hypertension, with AFib, and with more severe heart failure symptoms. So if we don't do something with this, we can certainly say that these patients are going to have bad outcomes. So what can we do? Well, we can operate on the patients. However, it's been shown from this series from 2019 that surgery for tricuspid regurgitation doesn't really influence mortality. So these patients, whether they're managed medically or surgically, the mortality for them is practically the same. There is a trend towards a better improved survival in the surgical group, but however, really there's very little difference, no significant difference in terms of the mortality at follow-up. So whether we replace or repair the valve, does that have any influence? And they've shown no difference either in terms of survival over long term, over 10, 15 years, whether the valve is actually replaced or it's repaired. But for these patients, so they undergo high-risk procedures, but we know that the recurrence rates are high for tricuspid regurgitation after surgery. And certainly in repair, they can be up to 35% at 5 years recurrent rate for moderate to severe tricuspid regurgitation. So can we do something maybe a little less invasive? So this is the Trival Registry, which looked at all types of tricuspid valve interventions, so minimally invasive or more or less minimally invasive, depending on the technique that was used. And this, for the first time, we've shown that there is survival benefit in terms of an intervention. So if we have a successful procedure, which is reduction to less than 3+ TR, and not only that, but we have an improvement in terms of symptoms. So we've now shown that if we do something with tricuspid regurgitation, we can show a mortality and we can show a quality of life benefit. So in the subgroup analysis of all patients that were treated, we can see that whether it's male or female, and these tend to be female patients that tend to have tricuspid regurgitation more than male. And so independent of the pulmonary pressures, of the degree of mitral regurgitation, or the presence or absence of a pacing lead, or even of severe left ventricular dysfunction, that an intervention with a technique has better outcomes than if we manage this medically. And I think one of the most important ones when we look at is in terms of right ventricular dysfunction. So when we're getting to the stage where the right ventricle is burned out and RV function is no longer normal, or there's significant RV dysfunction, these are the patients who, unfortunately, we've maybe missed the boat and sat on for a little too long. So it's a complex anatomy, and with complex anatomy come a multitude of solutions to try and deal with this. So they're broadly categorized over four types. So there's direct annuloplasty with a ring or with a stent. There's coaptation enhancement, so where we try to actually bring the leaflets together, and that obviously improves the regurgitation, but also can have an effect on the annulus by bringing the annulus close together. And then there are different types of valve replacements that have been proposed, and there are a multitude out there. But it comes back to what we know and what's been trusted. Bernard has already spoken about the edge-to-edge technique with the Triclip. So this was then a progression of it was, well, if we can do this in the mitral valve, can we do this in the tricuspid valve? And we can see from the registry that the majority of cases have been treated with the Triclip, using an edge-to-edge technology to try and reduce the tricuspid regurgitation. So this has been developed, and with the first proof of concept with the Triclip has been taken and has been adapted more to the tricuspid annulus, and hence the Triclip has become available. So the Triclip has a CE mark now for severe tricuspid regurgitation with a coaptation gap of less than 1 centimeter. So that's the gap between usually the septal and anterior leaflet needs to be less than 1 centimeter to allow actual grasping of the valve leaflets and successful clip placement. This is for patients who are at high surgical risk, who do not have severe mitral regurgitation or severe pulmonary hypertension, and who remain symptomatic despite optimal medical treatment. And I should say that now pacing leads are not a contraindication for this procedure. So in functional tricuspid regurgitation, what we get is annular dilatation. So you can see that the septal leaflet is obviously anchored in the septum, and the dilatation occurs in an anterior-posterior direction. So the ideal clipping procedure is where we anchor the anterior leaflet, which we see as the largest leaflet, to the septal, and using 1 or 2 clips to reduce to approximate the leaflets and reduce the mitral regurgitation. So we can see with this also that we're going to have an effect on the annulus also, because we're approaching the free wall to the septum and therefore reducing the annulus also. So this is the most effective area to place the clip with the best outcomes. So if we try and clip the anterior to posterior here, we're not anchoring to the septal leaflet. So we're going to have less effect on the tricuspid regurgitation and on the subsequent annular remodeling. So what is severe tricuspid regurgitation? And this is where it becomes very important, the relationship with the your echocardiographer. And we have certainly seen from the beginning of the program that is absolutely key, because the procedure is only as good as the images that we have and as good as the echo images, and specifically for tricuspid regurgitation and the TOE images. They're critical to the procedure, and it's a critical part of patient screening, the TOE, in terms of the quality of the images. And it's important. There's a very long and very detailed TOE protocol that must be followed, because we need to be able to see the tricuspid valve very clearly in order to successfully place the clip. Tricuspid regurgitation is notoriously difficult to grade, and it depends on loading conditions and the patient's volume status at the time of the echo. And sometimes it's maybe not just one exam that needs to be performed, but it's actually over a series of multiple exams that the decision on the severity of the tricuspid regurgitation will be made. But we know that once the vena contracta gets over 7 millimeters in diameter, that's where it starts to become significant. And we know that intervening on patients at this stage, once they're over 7 millimeters 7 millimeters in diameter, that we can see benefit for those patients. So I'm just going to show you a little video of the procedure. So it's in fact almost more simple than the mitral clip procedure. There's no transeptal, obviously. It's through a 24 French venous system. And here we see the clip in the right atrium, which is steered down the tricuspid valve. And the aorta is associated with the anterior leaflet. We have the septal and posterior. So we orientate ourselves with the aorta and the septum in order to find our ideal positioning. So we always start in the anteroseptal commissure here, because if we start positioning in the septo-posterior, it makes the imaging very, very difficult after the procedure. So there are quite a lot of issues in terms of reverberation from the clip itself. So this is why we always start in the anteroseptal. So we steer down with the clip open and position ourselves under the leaflets. So it's the same as the mitral clip procedure. Once we are happy that we have tissue within the clip, the grippers are placed down and the clip is closed. And at this stage, then there is a series of echocardiographic views that are taken to determine the success of the procedure and the need or not for a second clip in the same anteroseptal or perhaps in the posteroseptal commissure. So echo is key, and multi-level imaging through the esophageal, this is esophageal and deep transgastric, in order to properly visualize the valve and properly visualize the leaflets. So here we see what we like to see for the procedure. We have lovely images. So we clearly see the septal, the anterior and posterior leaflets, and the clip being steered down into the valve, where we have the grasping view here. 3D is also extremely important in terms of the orientation of the clip and the positioning in the appropriate commissure. So the Triluminate study is the study of the Triclip, which is published its 1-year results. So it's shown a very effective procedure and 93% survival at 1 year. And we can see that there has been a sustained improvement in reduction of TR out to 1 year. So here we see at inclusion at baseline. So from up to 1 year, we've had 70–80% of patients with no more than moderate TR follow-up at 1 year. We've shown that there is a 40% reduction in hospitalizations at 1 year, and also over 80% of patients are at NYHA 1 category at 1 year follow-up. So significant mortality and morbidity and hospitalization benefit for the procedure. So our experience with Triclip has began a program at the end of 2020, and so far we have 8 patients treated with an average of 2 clips and a procedure time of about 90 minutes. So we've had 100% procedural success and with reduction of more than 2 grades of TR for the procedure. So these patients need to be very carefully selected and carefully screened. And it goes back again to the importance of multimodality imaging, the importance of the transthoracic, but most importantly, the TOE in terms of choosing your patients carefully, and a multidisciplinary approach in terms of identifying these patients and identifying them early, because once the RV function has been impaired because of the left and right-sided heart failure, those patients are unfortunately at the end of the spectrum, and they're maybe not the patients who are really going to benefit from this procedure. So, so that's again the importance in terms of making the colleagues aware that this is now a disease that we can treat, and it's something that's important, and there are always new techniques coming online with it. In terms of the risk evaluation, it again comes back to a heart team decision depending on the risk of the patient for intervention, whether this should be offered surgery, and of course afterwards, depending on their imaging, what is the most suitable technique, and if they have appropriate echo windows, the benefit of the MitraClip for these patients. And particularly in terms of follow-up, it's very important that these patients are seen regularly at follow-up, and that we don't reduce or stop their heart failure treatments once they have had the clip inserted. This is something that's progressive over time. These patients should be discharged on the same diuretics, on the same medications as pre-procedure, and seen at 1 month afterwards, because it's certainly takes some time for the remodeling in the RV and the improvement in the tricuspid regurgitation. So these patients need to be intensively followed up and have intensive medical management after the intervention. It doesn't just stop there. So I'd like to thank you, and if there are any questions, I'd be delighted to
start the question. Thank you very much. Antoinette, you said that the mechanism of tricuspid regurgitation, the same for the mitral, depending on the cusp, on the commissure, on the ring. So you have a lot to do. You have a lot of techniques, but they are different mechanisms. So do you start doing 3D first, and they saw the mechanism, and then exact device, because the surgeon differs. The surgeon go for visualize the valve, and they go with the contents of the valve. We are seeing things by his eyes. I mean, if there's a mitral or tricuspid, he knows the mechanism in situ, but we are a cardiologist, we are doing blindly. So we have to know the mechanism first to choose the best device for the main mechanism of the tricuspid regurgitation. Do you understand me?
Yeah, I mean, any treatment for which there are multiple treatments available means that not one fits all. So we particularly see that in terms of the tricuspid valve. There are a multitude of different treatments available. And when it comes to functional mitral regurgitation, as we said, mostly the dilatation occurs in the anteroposterior axis. So that's why that the edge-to-edge technique can fit most patients. If we see from the Triclip registry, most patients were actually treated with the MitraClip or the Triclip afterwards, because with the dilatation that occurs, it occurs most anteroposterior. So if we can if the gap isn't too large between the septal and the anterior leaflet, so less than 1 centimeter, these patients can actually be treated successfully with the Triclip. For surgery, I mean, most of the surgical interventions for the tricuspid valve will be an annuloplasty ring. That's I think the most common procedure performed on it. Repair and surgical repairs, their outcomes they're not as good in terms of the annuloplasty with it, so they can have a recurrence of at least moderate MR in up to 30% of patients. So I think the surgeons use multiple techniques also, but I think for the most part, annuloplasty seems to, with a ring, seems to be the most commonly performed procedure. Again, because of the stretch in the annulus, it's all because of volume and subsequent pressure overload in the RV due to the left-sided heart dysfunction in a structurally normal valve.
So we can use mixed? You can use mixed?
Absolutely, yeah. I mean, there have been. I mean, this is all. It's an emerging technique. We're learning about it all the time, and certainly, as with the mitral, maybe annuloplasty with edge-to-edge repair can, in certain cases, be used.
Excuse me. You think a patient have long-term tricuspid regurg and developing some disturbance in his liver function? You think from your experience you will get benefit. This patient is considered high surgical risk. You think from your experience you will get some benefit from this procedure?
I mean, it's always it's when is it too late, and how early is too late? It's always this question. And I particularly think that if patients have significant comorbidities and have significant coagulopathies or cirrhosis, I mean, they're extremely high risk patients, and it's hard to see that they're going to benefit from this. I think a lot of it has been shown that it comes back to the RV function. So if the RV function is severely impaired, and those patients are unfortunately probably too far in the disease process to benefit from the technique. Coagulation problems on their own can be multifactorial. I don't know that should be a complete red card on its own, but I think particularly assessing the RV function is critically important.
During follow-up of your patient, do you report any signs of thrombosis on these clips, or do you have any data about that?
Don't have any data on that. A lot of these patients are going to have concomitant AFib. Again, as I said, the functional tricuspid regurgitation, it's independently associated with that. So they're going to have an indication for anticoagulation apart. So the AFib is their indication. So a lot of them are already on anticoagulation. Other than that, we've been using aspirin and Plavix for 3 months. It's sort of arbitrarily, but the majority of patients will already have an independent indication for an anticoagulant, but we haven't so far seen thrombosis as a problem, nor has it been reported in the Triclip and in the registry.
Yeah, thank you very much for your lecture. Do you think in the tricuspid regurg and the severe dilatation of the tricuspid and the severe pulmonary hypertension with the pressure is more difficult, or you have some contraindication to do this?
Yeah, I mean, if you go back to the CE mark for the Triclip, I mean, and in the Triluminate study as well, it's a contraindication to the procedure, so severe pulmonary hypertension. But these patients, I mean, it's so dependent on their loading conditions and on their volume status when you do that echo. So I mean, I think it's important that you don't just outrule the case on the basis of one echo. It's more on the basis of a continuum, and see where they are when they're optimally medically managed, and even when it comes to the coaptation gap as well. So sometimes maybe these patients need to come in and be managed intensively for a short period with maybe, dobutamine, furosemide, to really try and dry them out, and reassess the echo at that stage. And that can be really very important. So I think it's, you know, we don't make the decision on one single point of at one single time point or on one single echo. You know, I think it's and that's how important it is that there's multidisciplinary and multimodality decision. So it's not, it's something that's dynamic, the decision with it.
Thank you so much for the great lecture. Also, I would like to ask you about, after you tethered the anterior leaflet and the septal together, you said sometimes you need to tether the posterior also.
Yeah.
So the first question is like, what % of patients you need to tether both sides to the septal leaflet, I mean? And the second is, with your follow-up of those patients, do you find like improvement in dimensions, like improvement in remodeling parameters? Maybe we can think about adding medications like ARNI that worked well with the left ventricle and remodeling and stuff for the long-term effect.
Yeah, I mean, absolutely. I mean, it depends on where the leak is. You know, you're going to position the clip where the leak is. And we always, as I said, start in the anteroseptal, because we know that if we don't start there and we start in the posteroseptal, our imaging is impossible. We can't see where we're clipping. So that's why we start, and we in this commissure, and we also know that it has the best outcomes in terms of the remodeling, so the RV dimensions. So I think, you know, we certainly start with first clip. As we two clips in the anteroseptal, is kind of what we have been doing. But then, I mean, you look at the base of the jet and where the leak is, and if we see that there's significant leak in the posteroseptal, then we clip in that direction also, because what we can, if we clip in both directions, we have sort of a V where we catch the septal to the anterior and posterior, and that has an effect on reducing the annulus. This all has to be, you know, we have to be very careful as well. These are extremely delicate leaflets as well. So, you know, we need to make sure we don't put too much tension on the septal leaflet and cause any tear with it. So it's, you know, it's something that we're learning. There are no hard and fast rules. I think you need to look at the clip that you've placed, look at the effect on the tricuspid regurgitation, look at where the jet is, and then make a decision about whether you need to clip in the other direction. But I think we can't just give a rule. It depends, really, as a case-by-case basis. And as you said, that the reason we don't change our medications straight away, or we don't make any changes to particularly to the diuretic regime straight away, is because it does take some time to see that effect on the parameters, on the RV function parameters. So I mean, over time, we see that there's a reduction in the RV diameters and diastolic diameter, and even in the RA volumes. So, but that certainly can take some time.
Excuse me, is your RV systolic function cut-off point below which you do not offer this technique, and whether you depend on fraction area change or TAPSE, or sometimes you ask for MRI, CMR?
Yeah, I mean, we actually we have started using, because, you know, echo again for RV function can be difficult, and we have actually started using MRI in these patients to assess their RV function. So for the patients that we've been enrolling recently, we've been doing, we plan to do an MRI in them before and then 3 months afterwards, just to see and have a very precise measurement of RV function. Again, we don't have any absolute cutoffs for it, for RV function. I think that, I mean, TAPSE and fractional shortening, TAPSE is probably the most reproducible in terms of estimating the RV function. But I think it will be interesting to see with emerging MRI data, actually, and particularly at follow-up to see how these patients, how they perform, and how the RV would perform afterwards. And it's important to say that, you know, you're not looking to, it's not like tricuspid regurgitation. You're not looking to eliminate the tricuspid regurgitation. It's not like an MR, because these patients need that outlet, and they need that that pop-off valve of the TR, because, you know, if you end up with a very good result and you eliminate the TR in these patients, because of the RV function, they can end up in cardiogenic shock and in a lot of trouble with it. So I think it's something that we're learning all the time, and, you know, we don't have exact precise cutoffs for it just yet.
Okay, thank you very much, Antoinette. Thank you very much. Okay.